Go live and start the proceedings.
Yes, ma'am, I'm working on it. We are live now, ma'am. I'm sharing the screen. A very warm welcome and good evening to each and everybody, those who have joined here through our delegate, through our faculty link, and all of those people, those who have joined us through the Core Connect platform. I welcome you all on AMOGS Emergency Obstetric Committee with UPCOG, Moradabad, Hapur, Bijnor, Jaunpur, Bareilly societies on the episode 14. With no delay, I'd like to introduce you all our convener, Dr. Bharti Maheshwari, who is Secretary UPCOG, and the lady needs no introduction, but yet I'd like to mention certain point. She is DIP in IVF and Reproductive Medicine, Germany. She's chairperson, FOGSI MTP Committee 2018 and 2020. Fellowship in Medical Education by MCI, FIME, Governing Council Member, ICOG. She has several other achievements under her name. A very warm welcome, ma'am. I'd like to introduce you all with our coordinator for today's program, Dr. Nutan Upadhyay, past president SOGS. The lady again needs no introduction, but yet I'd like to mention few of her major accomplishments. She's MD FICOG, life member IMA, FOGSI ISAR, IFS, UPCOG, and certain others. A lot of awards are under her name, some of which are felicitated with Nari Shakti Champion Award, awarded under Pradhan Mantri Surakshit Matritwa Abhiyan. I am a UP President's Appreciation Award, a lot of other awards as well. A very warm welcome, ma'am. And for further proceedings, I'd like to hand over the session to you, ma'am. Please proceed.
So good evening, everyone. Namaskar and greetings from Uttar Pradesh, UPCOG. With AMOGS Emergency Obstetric Committee, main initiator, and as well as Dr. Sneha Bua, that who has taken this initiative to coordinate all of us, AMOGS and UPCOG, as well as few societies of UP like Moradabad, Hapur, and today's Bijnor. And this is really welcome you all in this very important topic discussion, as Dr. Sneha has designed this program very beautifully, because we all know that nowadays we have emphasized on the decreasing cesarean deliveries, and we all know that today that it is really very tough task to train the doctors and to actually implement the obstetric practice, especially in the difficult deliveries. So today's topics are mainly focused on the things that how we can manage the difficult deliveries, especially shoulder dystocia and instrumental deliveries. And for that, none other than we have very good speakers, that is Professor Dr. Reena Srivastava. She is the past president UPCOG, and as well as we know how academic and active she is. And then other speaker is none other than Dr. Parikshit Tangsar, because though he belongs to Mumbai, but for last 20-25 years we are associated with him. Like I have seen him even 15-20 years back in the UPCOG conferences at Muzaffarnagar Medical College. So, sir, I am big fan of you, being so simple, so humble, and always give your silent presence and very informative lectures. So, welcome you both speakers as well as chairpersons and my dear Nutan Upadhyay. I am so proud of you, Dr. Nutan, that you are taking this responsibility so beautifully, so enthusiastically. I really appreciate your efforts as well as your these initiatives to organize these things. And now we all know that Dr. Sneha, she is such a dynamic, such a academic, and such an active lady. We are seeing her activities for last, I think I am in her touch in last 7 years. And in her committee, she has done wonderful, and still she is doing. So, first of all, I would request Dr. Sneha to just introduce this program and say a few words. And after that, Dr. Nutan, please continue the proceedings of this event. Yes.
Thank you, ma'am. Thank you, Bharti, ma'am, for starting this session on such a beautiful note. And I'm really thankful to all the seniors and our chief, all honored guests who have joined and are giving their blessings. Now, I would request Dr. Sneha Bhuiar, ma'am, to please introduce and take our the webinar to the further proceedings.
Dr. Nutan,
Sneha Bhuiar,
Sneha
ma'am,
का
please.
Dr. Sneha का CVB introduce कर दो आप, Dr. Sneha का.
No worries.
अच्छा मैं अच्छा ठीक है.
It's okay. No need for
okay.
formal introduction.
Okay, Dr. Sneha, at present in this forum, she doesn't need any introduction. I agree. So we proceed forward. Yeah.
Okay, so a very good evening to one and all. My respect and regards to all the seniors of AMOGS as well as UPCOG. A very good evening to all the respected seniors, especially for the blessings of the chief patron, Dr. Usha Sharma, Padma Shri Madam Usha Sharma, and Madam Meeraji Agnihotri, also Madam Chandravati, and of course the today's chief guest, Dr. Narendra Malhotra, sir. Sir, welcome. And Madam Jaideep Malhotra, who are both of them my mentors since my entry to Foxy. And Madam, I welcome Madam in her absence because she's traveling for Aspire. And of course, the guest of honor, Madam Anuradha Khanna. I welcome the entire team of AMOGS, especially Dr. Kiran Kurtakoti, the president, Dr. Bipin Pandit, secretary, and immediate past president of AMOGS, Dr. Rajendra Singh Pardesi, my mentor, and Dr. Parag Biniwale, the ICOG chairperson-elect and national coordinator of AMOGS. I welcome the speakers, the illustrious speakers for today, both of them. I'm sure you will enjoy listening to them, Dr. Reena Srivastava and Dr. Parikshit Tang. The topics Dr. Bharti has already highlighted, so I'm not going to say much about it. The very aim of this discussion is always not only to reduce the mortality and morbidity, but also to optimize the cesarean section rate and of course to optimize the pregnancy outcomes. And that is why we have planned the panel discussion on the antepartum hemorrhage as well. So I welcome all the panelists, the respected chairpersons. I welcome the President Secretary of Hapur, Bijnor, even the, I think, Bareilly, Muzaffarpur.
Moradabad and
Moradabad.
Jaunpur also.
Yeah. Moradabad and Jaunpur. So all the 5 society president, secretary, and the entire team of these societies, I welcome all of you. And without much ado, I would like to welcome our chief guest for today's program, Dr. Narendra Malhotra. Piyush, can we have Sir CV?
Dr.
It's okay,
Sneha,
CV
we
not
have
required.
Dr. Pardesi also. I can see
Yes.
him. Yeah.
I
He has
already
logged in, Dr. Pardesi, Dr. Malhotra, I can see, and Dr. Anuradha, madam. The 3
Yes.
seniors are there.
Yes, Bharti, we have already welcomed sir, and I'm going to have his blessings also. So, sir, of course, doesn't need any introduction. So, not to spend any time on this, the CV slide is very, very busy, sir. I would just say name the organization, and sir has headed it, and he is the mentor and guide for many like me. So, with this, I would like to have your blessings and your words, precious words, sir. Over to you.
Thank you very much. Greetings to all the AMOGs and the UP doctors who are attending this wonderful program. And it is so very important for us to learn about obstetrics, because today we see that the youngsters are not interested in delivering babies, and they have forgotten the art of instrumental delivery. And if shoulder dystocia happens, then they panic. And this was actually because it's cesareans have become more, nobody wants to take risk, and vaginal delivery, the art of vaginal delivery is being lost. So having webinars, having video displays, having workshops on such topics is very, very important, especially for the PG students and young practitioners. Most of you want to practice infertility, cosmetic gynecology, laparoscopy, But remember, it is obstetrics which will give you the name and the fame. And then, of course, you can diversify into very much anything you. So first 10 years of your life of practice should be only obstetrics. And of course, giving advice on the other parts. And then you can choose whatever you want and specialize and sit at home or what you want to do. So shoulder dystocia, a very important topic. Instrumental delivery, very, very important topic. And APH, of course, we are all faced with it day in and day out. So I wish this conference a grand success. I wish all the best. My very, very best wishes to Bharti and to Sneha Buyar for their journey and all the others who are involved for their journey into Foxy. And you deserve to come up and you deserve to be a part of the mainstream of office bearers of Foxy. So congratulations to all of you for organizing this wonderful conference. I have to go because I have a labor case waiting who will probably require a forceps delivery. So you'll excuse me here. I'll put it on speaker and listen to what you all are talking. Thank you for
Thank
inviting
you.
me.
Thank you,
Thank
Naren
you.
sir.
Thank you.
Your presence is always very much inspiring. Thank you. Thank you.
Thank you so much, sir, for your blessings. And of course, you are the inspiration for all of us. I'm sure the youngsters who are listening to you definitely will introspect once again and try and learn the art of vaginal delivery, I would say. Thank you so much once again. So, with this, may I request Piyush to have Madam Jaideep Malhotra's CV? I would just say a few words about Madam because in her absence, I just welcome her and thank her for all her blessings and support for whatever endeavors I go for. So, Madam, again, a very illustrious personality. Apart from her, being a very good entrepreneur and, of course, a very loving and caring lady, and, of course, the leading obstetrician and gynecology, inspiration for so many of us. So, I thank Madam Jaideep Malhotra. And with this, I would like to have the blessings of Madam Anuradha Khanna, who is the immediate past president of UPCOG, the ex-head of Department of Obstetrics and Gynecology of Banaras Hindu University, ex-president of Varanasi Obstetrics and Gynec Society. And of course, Madam has got lots and lots of awards and accolades, and she has held so many posts. So, we'd like to listen to you, Madam, rather than reading your CV. Your precious words, Madam. Over to you.
Thank you so much, Dr.
Madam Anuradha Khanna.
Yeah.
Yes.
Am I audible?
Yes, ma'am, you're audible. Welcome, ma'am.
Thank you.
Anuradha, ma'am, welcome.
I'm so delighted to be a part of this excellent webinar series, and my all best wishes are with you, Dr. Sneha and Dr. Bharti and Dr. Nutan. You all are doing an excellent job, and I know by this way we all as a doctors, as academician, as a practitioners, we are raising and updating us regarding the different aspect of obstetrics. Obviously, that is very important said by others. And Dr. Reena, who is as better than to talk about this aspect of this shoulder dystocia, and also about APH we are going to discuss, and the other things of obstetrics we are going to discuss. So obstetric is always a nightmare. Just before that, Nutan, you were calling me, and I was discussing on another phone regarding the post placenta accreta emergency going on, and I was advising them to go to this, tertiary center, IMS, BSU. Don't waste your time. Don't waste your time. Not because once it goes towards the multi-organ failure, then it cannot be reverted back. So it is also my sincere advice to all those who are listening that though you have opened your ICU, but just take care whether your ICU is up to the mark or not. Is it managing all the aspect? Because in ICU, it is a multidisciplinary part. So if you have got all the consultant of all the departments available, then it is good. Otherwise, before she'll end up in multi-organ failure, you have to refer to a place where the tertiary care are there. We know all about the more of the theoretical part, but what is more required is the practical part. And that is not only this, you are going to save yourself also from medical legal aspect. So this is my message only. to focus yourself on the clinical part and also saving you from medical legal aspect. Thank you so much for inviting.
Thank you so much, Madam,
Thank you, sir.
for your words of wisdom and guidance, of course. With this, I would like to thank all the guests, and I would like to say a few
One
words
more
to
thing,
Dr.
Dr.
Rajendra
Sneha.
Singh.
One
Yes,
more
ma'am.
thing to Sneha. My
Yes,
all best wishes are with you. You are an
thank you.
excellent person, excellent in all the aspects, and Dr. Bharti Maheshwari, you also. Thank you so
Thank
much.
you, Madam. Radha, Madam. Thank you. Thank you very much.
Thank you, ma'am.
Thank you so much, madam. I would like to have the blessings of my mentor, Dr. Rajendra Singh Pardesi, who is the immediate past president of AMOGS. And of course, all of you know him so well. So without much ado, we would like to listen to his words. Sir.
Everybody, respected Dr. Usha Sharma, Dr. Chandravati, Dr. Mira Agnihotri, and our inspiration, Dr. Narendra Malhotra, Dr. Jaideep Malhotra, and Dr. Anuradha Khanna. As she told very rightly about all, and I think we cannot forget Dr. Anuradha Khanna's AICUG, I think 2012 in Varanasi. Madam, so we cannot forget your warm hospitality at that time. And of course, with the UP President, Dr. Kirti Dubey, Secretary Dr. Bharti Maheshwari is our folksy friends since a long. Treasurer Dr. Priyanka Garg and our President, Dr. Kiran Kurtakoti. First, I wish to congratulate Dr. Sneha Bhayar and with UP societies for organizing this webinar, which is useful for day-to-day practice and which is very useful to reduce maternal mortality rate and to reduce cesarean section rate also, because now cesarean section rate is debating all over. And with the galaxy of speakers like Dr. Reena Srivastava, Dr. Parikshit Tang, Dr. Sneha Bhayar, with chairperson panelists, I think this is going to be a great event. See, AMOGS, we are doing essentially our practical events also. And just, I'm proud to tell you that Dr. Sneha Bhayar, she has conducted more than 100 programs on PPH, PPH, PIH eclampsia, like hypertension, disease, pregnancy. And she is really dedicated for women's health and especially to reducing MMR rate. I wish every success to Dr. Sneha Bhayar for our future endeavor as Vice President Foxy. Wishing every success to this webinar also, every success to Dr. Bharti Maheshwari also for future, and Dr. Parag Biniwale also. Thank you so much for inviting me. Thank you.
Thank you, Pardeshi sir.
Thank you, sir.
Thank you for coming in this forum and giving your blessings. And really nice to see you and to hear you. Thank you, sir.
Thank you so much, sir, for your blessings always. And may I request Dr. Parikshit Tang to, he's really.
Dr. Sneha, Parag Biniwale sir bhi aa gaye hain.
I know. But Dr. Parikshit, in a hurry, I'm going to, by the time Dr. Parikshit
Okay.
is free, I would request Parag to say a few words.
Yeah.
Yeah, I'm so sorry. Because
Thank you, Sneha. Of course, Parikshit is looking very restless, so I'm not going to take much time. Thank you for the invitation, Team AMOGS and Team UPCOG. Pleasure to see Dr. Reena Srivastava and Parikshit as speakers. And of course, I have very fond memories of midterm UPCOG last year in Hapur, when I was invited as chief guest, which was a big, I would say, honor for me. Though I have not visited other societies, that is Moradabad, Jaunpur, Bijnor, and Bareilly, I hope to visit these societies soon, though I have visited all of them virtually. Sneha, I must appreciate your endeavor in teaching the obstetrics, because that is something which is so important and it will definitely have a great impact on the maternal mortality. My best wishes to you for your forthcoming elections and best wishes for the program. Thank you. Parikshit, I was very short.
Thank you so much. Thank you so much. Always appreciate them. So again, I would like to begin by thanking this absolute galaxy of people and faculty who have gathered here at the invitation of Dr. Bhuyar and Dr. Maheshwari. Wonderful to see all of you. And indeed, it's a proud moment to give a talk to such an august audience. So I was asked to speak about instrumental vaginal delivery, and I thought I'll focus on one aspect of it, and that is enhancing safety. So is it an essential skill? And Dr. Malhotra did mention that, youngsters are now not doing too much of obstetrics. And is that instrumental deliveries have an established place in obstetric practice. They can actually, prevent difficult cesareans where you might have to operate at full dilatation, low station. Those aren't easy either. Overall, some reduction of cesarean section rates might be achieved. And if you really are in a soup with the baby going down, this is the kind of intervention which can save the day. Why are we forgetting this art? I mean, it's rooted in fear. And that fear starts at various points. It starts from how the woman approaches you in the antenatal clinic. It comes from how you have been trained and your experiences. But ultimately, fear leads to avoidance. Avoidance leads to de-skilling. You don't practice it, you don't have a good hand at it. And when you do something which you're not used to doing, you get undesirable outcomes. And the moment you get an undesirable outcome, your fear is going to multiply. So it's not with force, but with skill. It's an art. How do we enhance safety then? You want to become fearless. Please understand that this is different from being careless. Idea is to practice by a protocol, have medical and medico-legal safeguards, and train yourself with simulators, see your mentors, and attend workshops and meetings like this one. So when we say practice by protocol, you have to establish an indication and rule out contraindications. That is your number one step. Then you have to have medical safeguards, like the concept of a trial instrumental vaginal delivery, choosing the right instrument, avoiding common pitfalls, and the concept of parallelism, on which I'm going to spend a few minutes. And then, of course, it all boils down to how medico-legally savvy you are, your counseling, consent taking, and documentation. So as such, today there is no place for a purely prophylactic delivery by an instrument. The standard indication is expediting delivery for some mother's or child's reason, and that stood the test of time. The indication influences the choice of instrument to a certain extent, but only to the point that you want to avoid a ventouse in preterm gestation. Certain contraindications have to be borne in mind. If you think there is definitely a cephalopelvic disproportion, don't bother. Malpresentations, absolute like bro and face with mento posterior, there's no mechanism. But today, even a face with mento anterior will probably be a contraindication. A high station cervix not fully dilated. And here I would like to point out that cervix not fully dilated is an important contraindication for the ventouse also. People have this misconception that, oh, ventouse will, the application itself will draw the cervix out. Please don't try to do this. And of course, if there are fetal disorders of structure or coagulation, then you have to think again about whether an IVD is applicable. Where do you draw the line? I mean, today, nobody practices a high application, and only a few dinosaurs are left who practice a mid application. Everybody else is low to outlet. But I believe that even if we do low to outlets, that's a training ground to go to mid. Should there be a trial? And I think every instrumental delivery should be a trial. It should be undertaken with the knowledge that there is some degree of disproportion. There is something which could go wrong. And I prefer to do it in the OT, under spinal anesthesia, everything prepared for a C-section. But the most important thing is know when to stop. Think of every IVD as a trial of IVD. It's better to be over-prepared in obstetrics. There's nothing like, calling one extra person. Is that ever going to harm anyone? No. When we talk about the ventouse, the most important thing is the application. The application needs to be right bang in the midline, and it needs to be as posterior as you can make the cup go. And that's what is going to allow two factors, auto rotation and flexion. So this is a wonderful example. I took it off the YouTube with the permission of Dr. Patil from Raichur. You can see application, you can see how he slides his fingers deeper inside to achieve the right spot. And then in this particular case, of course, he's building it by foot vacuum. There are various instruments which can do the job for you. Now, the problem is ventouse pop-offs. Why? Why do they happen? Incorrect selection. Obviously, too big a baby won't come out. Incorrect application, not as posterior, not in the midline, or incorrect traction. So, apply traction and counter traction with the thumb of the left hand, pushing the cup onto the baby's head, and traction with your right. If it pops off, remove it, reassess, and then re-up. But if it pops out the second time, stop there. Don't keep on trying the same. The real reason why IVDs fail in clinical practice, the obvious ones we know, CPD, high station, cervix not fully dilated, but what's below the surface is malrotation, deflection, and asynchronous. These contribute and they can fox even the most hardened of obstetricians to making a mistake. This is where the concept of parallelism is very useful. So here you have the typical situation. You can see this is the sagittal suture. It's tilted a bit posteriorly. You're applying the blade, and these are parallel forceps blade. What I would like to draw your attention to is that the lock is not at the same level. See, this appears ahead, this is behind, and you will have this discrepancy over there. But as you start pulling the baby down along the curve of Keras, this asynclitism is going to get corrected. And that's how you get the minimum injury to the pelvis or the fetus. And this concept is something which has really helped me over a period of time. Is consent mandatory? Well, ideally any medical procedure, you should have a consent. But some argue that IVD is life-saving and you just do it because you're acting at the best interest of the mother or baby. But I think, those days are gone. Please take a consent wherever it is possible, feasible. And always document what has happened at the time of that instrumental delivery, including the indication, why you did it, what was the thought process, what was the position of the fetal head, whether there was molding, caput, whether there were injuries, so on and so forth. And that really completes the job for you. We don't have that many obstetric, probabilities for training. So we have to think about mannequin-based training models, and it's ultimately the hand holding, which is absolutely essential in this regard. Future, we are going to see the ODOT device coming in. I don't know how that's going to pan out in India, but it's exciting times in that respect. And I thank you all very much for your kind attention.
Thank you. Yes. Thank you, Parikshit sir, for such crisp and such a to-the-point discussion on the relevant parts of today's instrumental vaginal delivery. And I think as sir is...
Like to have the chairperson's comments.
Yeah, yeah. I thought that he's logged out. I would like Dr. Mridula Sharma, Dr. Uma Sharma and Dr. Shubha Singh. Because of the shortage of time, we couldn't introduce you earlier. But Dr. Uma Sharma and Dr. Shubha Singh, ma'am, can you just conclude this talk, please? You'll have to unmute yourself. Dr. Uma Sharma, ma'am, kindly unmute yourself.
Madam Uma Sharma, please unmute yourself. Unmute yourself.
Madam, unmute ka button daba lijiye, please. Thank you. Yes.
Thank you, ma'am, for making the part of this prestigious webinar. Just to conclude, I want to say that one should have a very well-informed consent before applying any instrumental delivery. Second, we should have a very valid indication, and the doctor should be honest whether he or she can give the services of instrumental delivery. Third, we should have a very well documentation at the time of intrapartum, vitals of the female, and all the documents related to vaginal PV findings. And in the last, one should have a very well documentation of Apgar score of the fetus. This is all about, I want to conclude.
Thank you, ma'am. Thank you so much for such a well conclusion of Dr. Parikshit Tangsar's talk. Now, we would like to go to the second topic of today's scientific program. And I would like to welcome our chairpersons, Dr. Archana Singh and Dr. Bijnor, who are the chairpersons. And I would like them to introduce our illustrious speaker, Dr. Reena Srivastava, ma'am.
Dr.
So,
Nutan,
first
you're
of all,
supposed to,
yes,
hello, Nutan,
yes.
you're supposed to introduce our chairperson, Dr.
Yes, I was
Archana.
waiting for, yes, ma'am. I was waiting for the CV. Yes, Dr. Archana Singh. Yes, Dr. Archana Singh is the present president of Moradabad society. She is she's also not only doing her obs and gynae, but she's also has a diploma in ultrasonography, and she has experience also in laparoscopy, hysteroscopy, and colposcopy. I welcome you, Dr. Archana, ma'am. And our next chairperson is Dr. Alka Bijnor. Can I have a CV? Yes, Dr. Alka Bijnor is the director, and she's a senior consultant and since 1922 in her nursing home. And she's also been the founder secretary of Bijnor OBG Society, and she's also the present president of the same society. She is also a very active academician. I welcome you, Dr. Alka Bijnor, ma'am. I welcome both the chairpersons, and I would request Dr. Archana Singh, ma'am, to read the CV, introduce our illustrious speaker, Dr. Reena Srivastava, ma'am.
Yeah, good evening, everybody. It is my pleasure to introduce our speaker, Madam Reena Srivastava, who is ex-professor and HOD, BRD Medical College, Gorakhpur from UP, India. She is past president, UP chapter and Ops and Gynae, past president, Gorakhpur Menopause Society. She is a fellow ICOG, North Zone Coordinator, SSNPP, FOXY, past treasurer, secretary, president, Gorakhpur Ops and Gynae. She has organized UPCOG in 2003 and 2016 at Gorakhpur, and she also organized NYFOGSI at Gorakhpur, organized CEPOG 19 at Gorakhpur. She has organized numerous CMEs workshops at BRDMC Gorakhpur Ops and Gynae Society. She has authored many chapters in many books. She has published many papers in national and international journals. She was felicitated by Dainik Jagran for outstanding work for humanity. She was also felicitated by Amar Ujala for outstanding work for humanity. And she was also felicitated by Global Health and Department of Family Welfare UP for outstanding work in family planning in 2016. I welcome you, madam. Please proceed with your presentation.
Thank you, Dr. Alka. Please, can I share my slides? Give me a few.
Yes, I think you can share it. Piyush, have you disabled, madam?
Can you see my slides? Okay.
Just make it full screen, madam.
Is it full screen now? Is it full screen?
Yes, madam.
Yes, ma'am. Yes, ma'am. It's full screen.
So first of all, my thank you, Dr. Sneha, for inviting me here, and Dr. Sneha and Dr. Bharti for organizing such a beautiful seminar and such an important and pertinent topics for today, well required by the people to know about it and to practice it actually. So I would be talking on shoulder dystocia. And first of all, I would like to say a few words about Sneha. She's very, very, you can say, good in academics. She is very hardworking, and I would like to see you for which you are fetching for in the future. My all hearty good wishes and blessings to you, Dr. Sneha.
Thank you, madam.
And
Thank
Dr.
you so much.
Bharti is also there. So to talk about shoulder dystocia, first about what are the major concerns about shoulder dystocia? and why it is so very important to know about it, to be practical about it, and to practice it. Because it is an obstetric emergency, it may come to any patient while delivering. We don't know who is going to be caught with this problem, and so it is a nightmare for obstetricians. Basically, it is rare to see, but once it occurs, it becomes difficult for an obstetrician who has not seen it in their career. And on the top of all this, it is neither well predicted nor well prevented. It can only be anticipated. With this, it is having a very huge maternal morbidity and fetal morbidity and mortality, and leading to a lot of litigations to the obstetrician. So what should be the objectives about it? We should be able to anticipate and identify cases at high risk of shoulder dystocia. We should be able to diagnose it, and then we should be able to manage it. Management part is for which we are concerned, because it needs practice, it needs skill, and maybe a lot of practice is required. And for this, I think in medical colleges and district hospitals of UP, it is going on, the mannequin skill practice by IHAT. This is what I learned a few days back. To define, it is a head-to-body delivery, time more than 60 seconds due to impaction of the shoulder, anterior mostly against the symphysis pubis, and rarely posterior shoulder at the sacral promontory. The old definition was use of any of the obstetric maneuvers to release the shoulder after gentle downward traction has failed. The incidence being different in different countries, but in total, we can say it is around 0.2 to 3%. And the reason for variations could be difference in the definition of shoulder dystocia, which was being taken initially now, variability between the study population, and the clinical judgment of the healthcare provider also. The mean time of normal delivery used to be 24 seconds, and the mean time of delivery with dystocia, if taken carefully and done carefully, would take 79 seconds. The pathophysiology for this would be that the diameter of the maternal pelvis through which the fetal shoulder attempts to pass is less than the bisacromial diameter of the fetus, and fetal shoulder do not rotate to the wider pelvic diameter. What are the predisposing risk factors? This is what we can anticipate in a patient. If these things are present in a case, we have to be alert that this patient might go into shoulder dystocia, although normal cases can also go into it. A previous history of shoulder dystocia, incidence being around 16%, but it is underestimated, because once a person gets a shoulder dystocia, mostly they choose a cesarean in the next pregnancy. Diabetes increases the risk by 70%. Obesity, induced labor, prolonged first and second stage of labor, secondary arrest of labor, post-maturity, multiparity, anencephaly, mid-pelvic instrumental delivery, then fetal ascites, macrosomia, precipitate labor, epidural use. It is not that in all these cases we are having this, but in few cases we might get shoulder dystocia, for which we have to be prepared for it. Then, what are the maternal complications? A patient may go into PPH with an incidence of 11% because of atony and because of soft tissue trauma, even 3rd and 4th degree tears. There could be symphysial diathesis and lateral femoral cutaneous neuropathy because of the aggressive hyperflexion which we are going to allow the patient while delivering this shoulder dystocia baby. Then there is increased oasis, obstetric and sphincter injuries, and this occurs with fetal manipulations. Then Genevall's maneuver and symphysiotomy may lead to, I'll tell you what are these. They may lead to cervicovaginal lacerations, uterine rupture, urethral injury, bladder lacerations. Then what could be the neonatal complications, which we are very much concerned? Total neonatal injury rate is around 5 to 0.2%. And the most important fetal injury that occurs is brachial plexus injury, around 10 to 20%, with a complete recovery in 50 to 80% cases, not all. And this brachial plexus injury mostly occurs as Erb's palsy, but maybe Klumpke's palsy also. There could be fracture of clavicle, fracture of humerus, Fetal hypoxia may present as neurological damage or death even. Then there are a few rare complications in the form of diaphragmatic paralysis, Horner syndrome, facial nerve injuries, spiral fracture of radius, laryngeal nerve paralysis. These are very, very rare. And this mostly if the fetus is held in any way, not knowing how to deliver it. A word about brachial plexus injury. And this is because of downward traction on the neck. Most important fetal effect this occurs and most common cause for litigation in shoulder dystocia. Now, can shoulder dystocia be predicted? Macrosomia itself is a weak predictor. Not all macrosomic babies are going to have ST. Majority of infants with birth weight more than 4.5 kg do not develop ST. So clinical fetal weight estimation is unreliable. Third trimester ultrasound has at least 10% margin of error. And even the most powerful predictors for SD have a sensitivity of say 10% and positive predictive value of 5%. Majority of SD occurs in no risk group. So clinicians should be aware of risk factor, but must always be ready for the possibility of SD in any delivery. So that needs a skill by all the clinicians who are practicing in the labor room. And the most important risk factors, as said by ACOG, is diabetes with macrosomia. Now, can it be prevented? SD can only be prevented by cesarean section. An additional 3,695 cesarean sections will be required to prevent one permanent injury out of shoulder dystocia. So we just cannot submit every patient having an anticipated risk factor to a cesarean section. Then coming to early induction of labor in diabetes and suspected macrosomia, if early induction was done, the rate of SD was reduced by 60% with no difference in cesarean section rate and the morbidity rate. But then ACOG questions this also, that will this reduction in SD persist if induced at 39 weeks? So again, we can't say that, yes, early induction of labor, we are going to get rid of SD. ACOG continues to discourage induction of labor solely for macrosomia. The final word given by them is a cesarean section for diabetes and macrosomia when the estimated fetal weight is more than 4.5 kg, and a cesarean section for non-diabetes and macrosomia when the estimated fetal weight is more than 5 kg. But in our scenario, I think this should be reduced to at least 0.5 kg in each case. A word about recurrent shoulder dystocia. The rate is 1 to 16.7%, and most studies say it is 10%, although it is underestimated. How to decide what should be the mode of delivery in these cases? Whether all of them should undergo cesarean? No, it is not universally recommended. You have to look for the estimated fetal weight, gestational age, maternal diabetes, and the severity of prior neonatal injury. With this, we have to discuss with the parents, with the patient herself, and take her opinion. According to that, you can go forward. And what the scenario where we are working, I think all of them will go for cesarean section. So how to recognize a case of shoulder dystocia at the time of delivery? When there is a lapse of more than 1 minute between the delivery of the head and delivery of the body. A gentle downward traction has failed to affect the delivery of the shoulders. Head either is tightly applied over the vulva or retracting, giving rise to turtle sign. Failure of restitution of a head. Then need to retract the perineum to see the face. It is jam-packed over the perineum. Then the baby is having fatty cheeks. It is bruised. There is a usual downward traction on a head doesn't result in appearance of the anterior shoulder. All these collectively will help in diagnosing whether the patient has already gone into shoulder dystocia. This is a turtle sign. So once we recognize what we have to do, there are so many do nots, like do not ask the patient to push now, do not pull the baby, do not apply fundal pressure. All these things are being done when the head is not delivered normally in any labor room. So it should not be done once we think that, yes, shoulders have been impacted. and do not panic even. We should have a preparedness if we have anticipated already that with the patient, we should have discussed with the patient previously and the family. Senior obstetrician, anesthetist, and neonatologist should be around. Empty the bladder, stay calm, and take the help of helper or alarmer. What is it? These two are almost same. Ask for help. Leg hyperflexion is the first thing we have to do. Then anterior shoulder disimpaction by Rubin 1. I'll tell you what are these. The rotational maneuvers next. Then manual delivery of posterior arm. Evaluate for episiotomy whether it is required. It would be required when internal maneuvers are to be done. And roll on all fours. The sequence varies with various authors and various. So each step will be taking 30 to 60 seconds if we are well acquainted and we are proficient enough to deal with these cases. For a total 3 to 5 minutes will be required. And no RCTs say that any of these maneuvers are superior. They represent a valuable tool, and with whichever the clinician is very well efficient and proficient can use it. So first was call for help. Episiotomy, whether required or not, that will depend upon when the external maneuvers fail and you think that now you have to go for internal maneuvers. You are able to put your hand inside or not, accordingly you give an episiotomy. First, everybody is advocating for using first the McRoberts maneuver. It was first described in 1983. It is to be attempted first, most widely adopted, and less neonatal trauma, and correction occurs in 90%. How to do? The mother is laid down flat with both the legs, thighs hyperflexed on the chest, one assistant holding each leg, and what it is bringing about. It is the pubic symphysis, as you can see in the picture, the pubic symphysis is cephalled over here. The sacrum becomes straightened, the lordosis reduces, the inclination of the pelvis reduces, and this helps the entry of the shoulders inside it. With this only maneuver, you might be successful in disimpacting the shoulders, and the shoulders might deliver. If it is not successful, then it can be added up with the suprapubic pressure in the way it is being given. I'll tell you just now in the next one. That is Rubin's maneuver. It was described by Rubin in 1964. It is a suprapubic pressure. Initially, Bareilly described it to push the dislodged anterior shoulder posteriorly beneath the pubic symphysis. Then Rubin said, no, apart from push it posteriorly, you have to press it towards the maternal, the fetal face. So that for that, we have to know which side is the back. The pressure downwards and towards the fetal face will further adduct the shoulders, reducing the bisacromial diameter and pushing it inside the pelvic diameter. So reduce biacromial diameter and rotate the shoulder into the wide oblique angle of the maternal pelvis. Now, if these two maneuvers fail, these two were external maneuvers, we need to enter in the pelvis, and we need to have internal maneuvers done. For the delivery of the posterior arm, number 1, number 2, Rubens 2, and number 3 is wood screw. These Rubens and wood screw, they are rotational methods. So first, the delivery of the posterior arm. This was first described by Bijnor in 1945. And the rationale is that by delivering the posterior arm, the diameter of the fetal shoulders will be narrowed by the width of the arm, which will help it to enter the oblique diameter of the pelvis. So in this way, you can see full hand is put inside. For this, anesthesia would be required. If the patient, I don't think the patient will allow to do it, and anesthetist that is why around us. So anesthesia would be required. A hand inside the pelvis towards the sacral hollow, palpate the elbow and go anteriorly over the fetal chest. If the hand is flexed, the wrist will be there. You can put catch hold of this wrist and bring down the hand in a straight line. This also tells you the same thing. You have to just go to the elbow, go to the wrist, catch hold the wrist and bring it down in the straight line. With this, the posterior shoulder is brought down, and then there is a space for the anterior shoulder to enter the pelvis, and so the shoulder dystocia is relieved. Now, the internal rotational maneuvers, Wood corkscrew maneuver and Rubin 2, they were described in 43 and 1964. The aim is to move the shoulders out of the narrowest diameter to the, that is AP, to the wider diameter, that is oblique diameter of the pelvis. This reduces the bisacromial diameter by adduction of the shoulders and utilizes the pelvic anatomy. Both these methods, initially when were described by Woods and Rubens, they advocated for fundal pressure, but now fundal pressure is out. It is not recommended now. So some authors say that their name should also be not there. Wood, corkscrew, and Rubin 2. So coming to Rubin 2, hand is placed in the vagina on the back surface of the posterior shoulder. I'll tell you in the photo. See, 2 fingers or hand, whichever is possible, place it inside the vagina posteriorly, take it on the back side of the fetal shoulder and press it towards the fetal face. So this will bring the bisacromial diameter to the oblique diameter. This you can see, sorry. This much of rotation is required to bring it into the oblique diameter, and with this, the shoulder dystocia might be disimpacted. Woodscrew says that rotate the posterior shoulder by 180 degrees. First, keep one hand on the anterior clavicular surface. Push the shoulder to from the AP to the oblique diameter. And if it is disimpacted, well and good. Otherwise, rotate it throughout to bring the posterior shoulder anterior. This is Woodscrew method. Actually, all these maneuvers need a drill and mannequin and the fetus, and repeated practice of these maneuvers are required. Last one is Gaskin's all-4 maneuver. You can see the position of the fetus, that is a knee chest position of the of the mother. The mother has to be put in the knee chest position. And this might be disorienting for the unfamiliar doctor, but yes, it increases the obstetric conjugate by 1.5 centimeters. And this itself may dislodge the anterior shoulder, then gentle traction for the delivery of the head is done. If this fails, then all the maneuvers which just now I've described can be done in this position. And few authors say that after the external maneuvers fail, instead of going to delivery of the posterior arm, you can put the patient in all 4 position and first attempt this one, because this gives a better way of disimpacting the shoulders. If all fails, then what to do? A deliberate clavicular fracture can be done by fingers over the fetal clavicle. Because once the clavicle is fractured, there will be reduction in the sacromial diameter. The fetus can be delivered, and then that clavicular fracture can be healed. Then Genovelli's maneuver, the uterus is retracted on the fetus, the head is out. If we put a hand and do something inside, it might lead to rupture of the uterus. But then it can be done by first giving tocolysis, replacing the head inside the uterus, and then doing a cesarean section. Symphysiotomy, there is always a risk of injury to the urethra, bladder, vagina, and cervix. Cleidotomy with a dead fetus, we have already done in so many cases by cleidotomy scissors, cutting both the clavicles by cleidotomy scissors. That will reduce the biacromial diameter, and then the fetus can be delivered. And last, few case reports also say that do open the abdomen, do a hysterotomy, and through that you can do the maneuvers, impact the disimpacted shoulders, and deliver the baby vagina. Now, post all these things basically really require practice. And just like when the PGs used to put the forceps, deliver the head, learn about it, how to apply the blade, how to give traction, the same way this has to be practiced. Otherwise, it will become difficult for a person who's not skilled and proficient about it in an emergency. So our post-delivery tasks are also there. You have to perform active management, be alert for PPH, assess for cervical, vaginal tears, uterine rupture, assessment of fetal well-being by pediatrician, counseling of the patient and family must be done. Events of the delivery have to be documented by all the members in the labor room. And what documentation? The significant facts like time of delivery, time of diagnosis of SD, involved arm, what all maneuvers were done, which was successful, what was the time taken to release shoulder dystocia, whether there is any fetal injury, what was done for that, any maternal complication. Discussion and counseling should be continued throughout with the guardians and the patient, and all routine documentation apart from this. So the key message would be that it can happen in any delivery. We have to anticipate and be prepared for it. Once it is diagnosed, every obstetrician should be trained to manage shoulder dystocia, because once it is diagnosed and you don't know how to deliver, then it is a big mess. And we anticipate this when a patient is having diabetes, macrosomia, obesity, post-mature, in all the cases where the fetus is a little more than normal weight. And on the top of everything, do regular shoulder dystocia drills to manage effectively when at all it occurs in emergency. So it cannot be predicted, it cannot be prevented, it can only be anticipated, and it can occur in any delivery. So SD delivery, the drill to be done for all those who are having labor room practice to improve the efficiency of all maneuvers and documentation to avoid litigation. Let us pledge to make birthing safe, and a big thank you to all of you for this patient listening.
Thank you, Reena Shrivastava ma'am. I would now ask Dr. Archana Singh ma'am to give her concluding remarks.
Thank you, ma'am.
Dr. Archana Singh.
Yes, ma'am. Thank you, ma'am. Good evening, everyone. Dr. Reena ma'am, your talk is very informative and very nice talk, and you explained everything very well. You explained many manuals which are very helpful to us, and I think after your talk, it is very easy to manage shoulder dystocia. Thank you, ma'am. Thank you so much.
Thank you, Dr. Alka Bijnor, Dr. Archana Singh ma'am, and thank you, Dr. Reena Shrivastava ma'am, for joining, giving such a academic entire journey of through the solving of the problem of shoulder dystocia. And this, it needs to be always to be learned and relearned. This is something that has to be
lot of drill is required.
Yes, ma'am. Thank you so much. And now I would like to go to the third part of our academic session, and we have a very, very interesting panel discussion. For that, I would love to invite our moderator, Dr. Sneha Bihar ma'am, to start this panel discussion. For this, I would like to also invite our experts, Dr. Mridula Sharma and Dr. Shazia Muniz. Dr. Mridula Sharma, ma'am, I would like to please chair this thing and introduce a dear moderator who is so well known to all of us. So before that, Dr. Mridula Sharma is the president of Bareilly OBS and Gynae Society. She is recently successfully organized the 35th annual UPCOG at Bareilly, in which it was a really a very, very enriching and academically very vibrant UPCOG. She is the director of Dharamdat City Hospital, Bareilly, UP, and she has been the alumni of Lady Hardinge Medical College, New Delhi. I welcome you, Dr. Mridula Sharma. Along with her, I have Dr. Shazia Muniz as our second expert. Dr. Shazia Muniz, he has been the past president of Moradabad OBS and Gynae Society, and she is the consultant in the Hope Clinic. She's also been the executive member of ISOPAV West UP chapter, and also the national coordinator of FOXI. So welcome, Dr. Shazia, our second expert in this panel discussion. I would request Dr. Shazia to please introduce our dear moderator, Dr. Sneha Bihar ma'am. Can I have the CV of Dr. Sneha Bihar?
Good evening, everyone. Am I audible?
Yes.
Dr. Nutan, am I audible?
Yes, Doctor.
Yes.
It is my proud privilege to introduce a very dynamic and a very humble person, Dr. Sneha Buyar ma'am. Although we all know her very well, she needs no introduction. And madam is very hardworking. And we wish you all the best for your journey for your vice president election. And thank you so much. And madam is the National Individual Award. Regarding the awards and accolades, she has received various awards. National Individual Award, Foxy 2008 for outstanding work in rural obstetrics, and many more awards. Dr. Ananda Bai Joshi Award by Government of Maharashtra, Foxy President Appreciation Award for Public Awareness in 2018, Foxy President Appreciation Award for exemplary work in cancer, WOW in 2019, and the Champions of Foxy Award in 2019. International MS Signature Award for Phenomenal Leadership in 2020. And there is a long list of the various awards. She has various publications in various national and international conferences and 25 articles and chapters in national publications. And she's also the peer reviewer of Jogi. And she has been the organizing chairperson of Pretty Care Nagpur in 2018. Zonal AMOGS in 2019.
Thank you.
Lectacon Pune in 2019. My God, so many credits to her points. Ma'am, we wish you a very best. And we hope to see you as a vice president soon. And I've also worked with you in the guest. Thank you so much, ma'am, and best wishes for your journey. Thank you so much.
Thank you so much. Thank you. I just invite all my dear friends and my panelists, Dr. Pragati Agrawal from Bareilly, Dr. Anita Chabaria. Yes, I think you can just display the first slide. I will just invite in Dr. Anita Chabaria also from Bareilly, Dr. Shaili Nikam from Jaunpur, Dr. Namita Agrawal from Hapur, and Dr. Neha Chandra from Moradabad, Dr. Mamta Jindal also from Moradabad. I'm sure all of you can stop sharing, Piyush. All of them are, Piyush, you can stop sharing. Yes. So all of them are very, well-read, I would say, Foxians, and I'm sure it's going to be a wonderful discussion. So without much ado, I would like to share my screen, and I hope all of you can see the screen. I'll just go to the first slide, and I will try to make it full screen. I hope all of you can see the screen, right? Can you see my screen?
Yes, ma'am. Yes.
Yes,
we can see it, Dr. Sneha.
Yes. Can you see?
Yes, Dr. Sneha, it's visible.
Yes. Thank you so much. I welcome all the experts, Dr. Mridula and Dr. Shazia Munis. I welcome all my dear panelists. And of course, I would say apart from all these national, international awards, may it be because of my academics or healthcare excellence, I'm a very hardworking, hardcore obstetrician, a private practicing obstetrician like majority of you. And I just take this opportunity to thank all of you, and also make an humble appeal to support me for my endeavor as Foxy Vice President from West Zone. So without much ado, we would start with the panel discussion with the very common cases which we all are facing in day-to-day practice. So may we start with Dr. Anita Chabaria. So Dr. Anita, we have this primary gravida with 5 months pregnancy. She comes with bleeding per vagina in the morning at home. It was painless in nature and without any cause. She was just relaxing, and suddenly she started bleeding. So on further inquiry, she revealed that even during early pregnancy, can we mute others? I think there is a lot of disturbance. I can. It is, yes. So now I think better. So when she gives history of spotting during early pregnancy, and on examination she's normotensive, non-anemic, uterus is 20 weeks lax, fetal parts are well palpated, and fetal heart is well heard. So at present there is no bleeding. So what is your diagnosis and how would you go ahead with the management? So let's have a look.
Thank you, ma'am. Thank you, Dr. Sinha, ma'am.
Yes.
When this patient comes to me, can you hear me, ma'am?
Yes, yes, definitely.
Yes, ma'am. When this patient comes to me in the OPD, I would ask her if she has any previous ultrasounds done. Usually, patients, when they come at 5 months, and if she has had history of previous spotting, she must be having an ultrasound.
Yes.
So I would like to take a look at her ultrasound if it is showing a low-lying placenta or anything like that. And second thing, I would like to do a per speculum examination also to rule out any cause, local cause like cervical ectopy or cervical polyp or any cervical ulcer. And I will also take a history of coitus before all of these episodes of bleeding. And my provisional diagnosis will be, madam, after seeing all that, I would be and label it. She can be labeled if there is no cervical polyp and if there is no cervical ulcer, and she gives a history that she did not have any intercourse before any of these episodes or any history of heavy physical activity, then an ultrasound shows normal placenta, then she can be a threatened abortion. Otherwise, I think it will be a case of low-lying placenta.
Okay. So I would ask you, when should you label any woman as having a low-lying placenta? What is the guideline? When can we
Ma'am,
label? Yes.
ma'am, low-lying placenta till after, it is only after 3.5 months, that is 14 weeks or 15 weeks of pregnancy.
Yeah. But then what is the distance from the internal os?
Ma'am, 3 centimeter.
Yeah, so it
More
is
than
1
3
or 2
centimeter.
centimeter from, if the placenta is 2 centimeter away from the internos, so we label. If it is completely covering, then we label it as previa. But then in this case, suppose you have ruled out all the other causes of the bleeding, and of course you've done her ultrasonography, you confirm that it's a low-lying placenta. Now, how do you take this pregnancy ahead? It's only 5 months.
Yes, ma'am. So I will first relax the patient verbally. I will ask her not to take any stress. If the os is closed, she need not, and the fetal heart sound is good, and on ultrasound examination, everything is fine. So, and I will ask her to relax, and then I might give her some anxiolytic to her, something like a little bit of diazepam or something, and I will ask her to be put on rest.
Is it, Dr. Anita, should we give her the anxiolytic? Should we give her?
Usually these patients are very anxious, ma'am.
Yeah, but
they are so anxious about it. So
yeah,
if she is
but
anxious, then we will
but then let me just tell you that she has to understand the fact that she's having this placenta previa and it's only 5 months. How many times you're going to give her anxiolytics? You have to take her to at least 34 weeks, right? So
yes, ma'am. And
I would
will admit the patient.
you give her, you allay her anxiety by your counseling. That is
counseling.
one. To give her certain instructions. So what are the instructions?
Yes, ma'am.
What are the precautions?
Yes,
Second
ma'am.
is whether you would like to go for os tightening, and third is whether you would like to go for any tocolysis. Yes, 1, 2, 3.
Yes, ma'am. First, I would like, I will ask her if I would like to admit the patient for observation for 2 days, ma'am, and then put her on rest. And also, I would like to give her some progesterones because they have seemed to have a good effect on relaxing the uterus. And for tocolysis, I will give her progesterones. And in the meantime, I would also do CBC.
If I can just interrupt you here, our patient doesn't have pain. Okay. In fact,
Yes,
we are saying that it is causeless and it is painless, right? And it is
Yes,
at
ma'am.
rest. So if
Yeah,
she
but
doesn't have
I'll do.
contractions, should we really give her tocolysis? See, tocolysis is different from progesterone. All of you agree to me?
Yes, ma'am. I don't think we need tocolysis in this case.
Yes.
In the
Yes,
term,
we do need
So
tocolysis.
I would ask the expert's opinion now, Dr. Mridula and Dr. Shajia. What do you think? Should you give her anxiolytic and should you give her tocolytics?
No, ma'am. I don't think we by proper
Either of the
counseling.
two are not required unless warranted
Yes.
because of any reason.
Yes.
And by
If
counseling
she is
itself,
having an irritable uterus along with this, of course, a tocolysis is
Yes.
required. But if
Yes.
it is
So
not
she's
there,
not having.
if it is
Right.
a quiet
and
uterus,
regarding
then progesterone, as you very rightly said, and Dr. Anita also very rightly pointed out, that progesterone, of course, certainly aids in it. But
Yes.
there is, at this point of time, there is no need to give
No
tocolysis.
role for tocolysis, correct?
regarding anxiety, I would say by proper counseling and explaining, most of the patients they understand and
Yes.
avoid straining. So this, I don't think.
And also, Dr. Anita, you're right in a way that you want to not take any risk, but you just give progesterone. That is okay. But
Yes,
there's no need for tocolysis. One thing is there's no need for tocolysis because she doesn't have uterine contraction. Secondly, long-term tocolysis is absolutely
not
not
indicated.
okay, not indicated. So as
Yes,
per
ma'am.
guidelines also, and even whatever we have been practicing, we are not using tocolysis. All of you know that this is not a point where we should discuss, but tocolysis, if at all you have to give, the rationally, either you should be able to, transfer the patient in utero, or your steroids and magnesium sulfate should work. So you should get at least 48 to 72 hours. That's the only point of time where you can give. Rather, you should give tocolysis.
Yes, ma'am.
Okay.
Yes.
Ma'am, even progesterone don't have any role in placenta previa. If we
Yes.
know that this bleeding is because of placenta previa,
Yes.
then there is no role of progesterone also.
Yes.
That
Now, that is what my next question is. Even for progesterone, there is no indication to give progesterone. Only thing is you have to, do the ultrasound in details. Now, two things here. You have just seen the location of the placenta. You have not looked for the retroplacental sonolucent zone, whether it is maintained or no, whether it is a adherent placenta that is passed. And secondly, the length of cervix, correct? If
Yes,
the
ma'am.
cervical length is short, then only, that is less than 2.5 centimeter, then only there is an indication to give vaginal progesterone, right?
Yes.
One thing that we can look in ultrasound is, ma'am, whether she is having a vasa previa or a velamentous placenta, because that color Doppler.
At this point of time, vasa previa.
Ma'am, color Doppler will definitely show
Yes.
that.
Yes, but then what difference it is going to make in our management at this point of time?
We can explain to the patient all the more, ma'am, she can know, because if she goes to another gynecologist and then that that doctor tells her, then she will be said कि अरे पहली वाली मैडम ने तो ये बताया ही नहीं था कि हमारा ऐसा भी है. So she needs to know everything about it, and then she could be.
That of course, yes. That of course, yes, because you have to be very transparent to the patient and you have to tell them whatever is evidence-based, okay? But vasa previa diagnosis at this point of time and explaining them, it's not going to help, because that you have to see near the term when she goes into labor, not to rupture a membranes, etc., etc. That is totally a different topic. We will be discussing it later. We are having a case for that. Okay. So here, whatever precautions for the low-lying placenta or placenta previa, that you have to give it to the patient. So
Yes,
what are those precautions?
Ma'am, I will advise.
Continue. Yes.
I will advise her rest and not much of physical activity, daily routine, light physical activity she can do, and not lifting weights, and proper 2 hours of rest in afternoon and 10 hours of sleep at night. And I will also ask her to avoid physical relationship with her husband and come for the
I
regular
would say
antenatal
intercourse.
checkup.
Intercourse. Okay.
Yeah,
Intercourse and internal examination. Okay.
Examination. Yes, ma'am.
Okay. So all these precautions, of course, she has to take it. Now, as I've already talked to you, that when can you diagnose this? What is the recommendation for low-lying placenta? You have to do the ultrasonography at around 16 weeks. See, all of us are now doing ultrasonography even at the first trimester scan. dating scan, then 11 to 13 weeks NT scan. So even during this period, you should be able to identify the low-lying placenta, but if not, at least 16 to 18 weeks is the period where you should identify that the placenta is low-lying or placenta is previa, and you should advise the patient all the precautions. Okay, now how do you take this pregnancy ahead? That question remains. Dr. Anita, please continue.
Yes, ma'am. After the
patient.
I will like you said, ma'am, that we will advise her adequate amount of rest, and we will also build her up hemoglobin. So because if she has a low lying placenta, she can bleed at a later date also. So her hemoglobin should be able so much that she can withstand that those losses. We will also advise her about the diet and nutrition, and to take her medicines regularly, and we will call her for if she has any more bleeding, if it is more, or if she feels there is no movement, she should immediately come to the hospital.
Yes.
And if everything is uneventful, if she is all right, then she can come 1 month later for a routine antenatal care.
Would you like to advise or keep her blood ready?
Yes, ma'am. I would like to advise her, though I would build her hemoglobin, but still I would advise her relatives also.
Even if her hemoglobin is 11 or 12, if she bleeds like a tap, we have to, so placenta
Yes, ma'am. We would.
always, yes. And
yes, ma'am. We would.
anything else, what we have missed out, I have just talked about that the location, it's not only the localization of placenta, but also you have to rule out that it is not morbidly adherent placenta.
To the placenta,
If it is
yes.
so, if it is so, then what will you do? Whether you would like to continue this patient in your individual nursing home, or you want to refer her to tertiary.
Ma'am, if to be honest, any patient that is diagnosed antenatally as placenta accreta, I usually refer her in early pregnancy only, because we at 20 weeks also we come to know there is like by our ultrasonologist is very good, and if there is anything like that, we tell her that she can continue for antenatal care if our clinic is near to her hospital, but for delivery and for any emergency, I would like to refer her to a tertiary center nearby.
Yes, so it's not only you and me, but the recommendation also suggests the same thing, and you are very correct, Dr. Anita, that we should confirm the presence of placenta previa, and we should also rule out the morbidly adherent placenta. And of course, the aim of our management should be to continue this pregnancy at least till salvageability, that is 34 weeks. If you can continue beyond this, definitely. If at all she bleeds in between any time, see what you have to, what do you counsel the patient's relatives? If you have a placenta previa, how do you counsel the patient and relatives? You are, yes.
If it is not an accreta, we have ruled out an accreta and it is only a placenta previa, then I always tell a patient's husband and relatives that we must have blood ready in case of emergency, because if she bleeds, then they have to come to the hospital, whatever be the time they don't have to wait at home. They have to come to the hospital immediately for me to assess. And also, I would ask them that not ask her to do too much of physical work.
Yes, that we have said already. So in spite of having a low-lying placenta, I will just say, in spite of, trying her best, that I give you instructions, you follow all the instructions, the blood and blood product, blood is also reserved for her, because the placenta is low-lying. Without any reason, she can bleed anytime. That is what your counseling should be. And the informed written consent should be in such a way that because the placenta is low-lying, even if all of us take any precautions, or rather all the precautions, she can bleed anytime and she may land up into operative intervention anytime. Okay. So you have to just continue with this pregnancy ahead. At around 32 weeks, again, you confirm that whether the placenta is low-lying. So, sometimes, fortunately, in continued growth of the pregnancy, it can be, little lateral or so, though it is not true migration of the placenta, but it can happen that it is little lateral, and you do have some, space or to take a decision on this mode of delivery also. And at 36, if you confirm that it is till the placenta previa, then of course you have to go for the planned or elective cesarean section. Now, what precautions you want to take before this kind of surgery? What all arrangement you want to do for this surgery?
When this patient is admitted for surgery, ma'am, I will have blood cross match 10 ready, and I will have 2 wide bore IV cannulas put in the patient, and one for fluid and one if I need the blood. She should be catheterized, and she should be we have already covered her with steroids at 34 weeks.
Steroids and even magnesium sulfate at around 32 weeks, because you
34
don't
weeks.
know at around
Then she can
32 weeks. Yeah, because
Yes.
you don't know what time she can bleed and you
Can
don't have
bleed.
anything in your hand. So steroids and magnesium sulfate at or around 32 weeks preferably should be, to prepare the baby. Okay.
Yes,
Then
ma'am. And it
what
should
are
be
the
a
precautions, what are the precautions
multidisciplinary.
when you take before the surgery? What kind of incision? Who all do you want in your team of this
Ma'am,
operative?
we want a good anesthetist, a good neonatologist, and I will also call one more gynecologist or a surgeon to assist me in that. Need the if in case of emergency, 2 hands are better than one.
Yeah.
Also, 2 minds are better than one, because sometimes we become very uncalm when we are doing such type of surgeries and the patient is bleeding a lot. So I would, beforehand, I will call another gynecologist or a surgeon, or I will tell them that we might call you at this time. So please be ready and keep yourself free to come and assist if we require.
Okay. Okay. Just before the surgery, you have said all the precautions necessary. I would just tell you what you have missed out. One is this has to be, posted as a planned surgery. Don't wait for her to bleed, right?
Yes, ma'am.
Moment she achieves the maturity, you find that it is salvageable, you feel that the lower segment is going to get formed. So before that, you have to plan the surgery, right? That is the only point. And of course, during surgery, what incision you want to take on the abdomen and on the uterus, and how do
Ma'am,
you
on
do
the
the
abdomen, I will like to give her a transverse incision, low lying, which
But
we
a
usually
liberal
give.
one. This time you
Yes,
need
a
like
liberal
some
one.
manipulation.
Yes, ma'am. So that manipulation is possible. And once I see the uterus, ma'am, and if I see the venous sinuses visible from once I see the uterus when I have opened the abdomen, then if I give a lower segment incision on the uterus, and if she might bleed profusely, I would like to go a little above and give a vertical incision. But in case it is not so, that not thick sinuses are visible and everything appears normal, I would give a transverse incision and rupture the membranes and take out the baby, and then take out the placenta.
Okay,
And
rest
also,
everything is fine, but what about the vertical incision? Other panelists, Professor Pragati?
Yes.
What about
Ma'am,
the
mostly,
vertical incision?
ma'am, mostly
At the
vertical
upper
incision is,
segment.
ma'am, mostly vertical incision is not required in placenta previa. If it is placenta accreta or it is placenta accreta spectrum in increta or percreta, then we will have to avoid the placenta. We will have to take the incision from where the placenta is not entered.
Yes, yes. So you have to map the placenta. See, your placenta is low lying, no? In fact, it is near the os. So you have lots of space on the lower uterine segment. Okay.
Usually the lower uterine segment incisions are absolutely fine.
Yes.
And we should be going for a lower segment section, I mean an incision only as much as possible, unless it is absolutely unavoidable. And upper segment, absolutely
In
not.
fact, I would say because it is a low-lying placenta, you
Exactly.
have space
You are
on
absolutely,
yes, ma'am.
absolutely. We have more space over there because since it is a central placenta previa, it is much lower. And the other thing is, before I take her up for surgery, I'll certainly like to explain it to her and to her relatives that there may be a possibility of going for hysterectomy because of all these profuse bleeding and the uterus not responding to the treatment after the delivery. So we may have to resort for hysterectomy. So that should be put in their mind. Because suddenly when we go out and we say, oh, we need an hysterectomy, then they are taken aback.
Yes, yes. So
Hysterectomy consent is always to be taken.
Yes, Pragati. Tell me.
Yes, I am saying that that should be informed before.
Exactly. Now, only one question to you, Dr. Anita. When you deliver the baby, what ultrasonic you want to give for this particular patient?
Ma'am, I would give her oxytocin.
Not carbetocin.
Yes,
Don't prefer carbetocin.
Ma'am, first, madam, I will give her oxytocin drip as soon as I deliver
Once
the
you
baby.
give oxytocin, you cannot give carbetocin. It doesn't work. They work through the same receptor. Once it is blocked, carbetocin doesn't work. Carbetocin is only for prophylaxis. Mind well, all of you. Okay. Carbetocin is only for prophylaxis, right? It doesn't work once the PPH starts. Okay. Likewise, the carboprost is only for treatment. It should never be given as prophylaxis.
Yes, ma'am.
Okay?
Yes.
Okay. So, as a prophylaxis, give carbetocin.
Okay, ma'am. And also cyclocapron we give, tranexamic acid also we give.
Yes, exactly. That is what I'm saying. While preparing this patient, you must give her even 1 gram tranexamic pre-operatively. 1 gram.
2 ampules. Yes, ma'am.
Yes. And of course, the carbetocin, one more intention of asking this is, because this is a lower segment placenta, the lower segment is the passive one. So even though all of us have stopped, almost minimized using methergine, this is a patient where there is a role of methergine because
it acts on the lower segment. Yes,
okay.
Segment. Yes.
So you have to take one. Don't wait for the patient to bleed torrentially. Give carbetocin, give methergine also. Okay. And then of course you pack the uterus, with a warm packs. You pack it, press it. Give some time for the uterus to contract and the vessels to get, compressed in between the musculature. Okay. And then of course, if there is still there are bleeding sinuses, then what do you do?
Ma'am, if there are still bleeding sinuses, I usually do bilateral uterine ligation, and that controls the uterine artery ligation, and that controls the bleeding. Even after that, if there is a little bit of oozing, then Cho's stitches I have applied many times, and that takes care of everything.
Okay, so figure of 8 stitches, simple one. By the time one person will take figure of 8 stitches, underrun the sinuses, and the other one will tie, ligate the uterine arteries, and of course the ovarian vessels also, if at all you have to really go. Okay, so if at all she bleeds, so then of course you have stepwise devascularization and the last resort as surgery. So this is how the placenta previa. See, here what they have done is they have incised the lower uterine segment. Pass your hand, the placenta below and the membranes above. You pass your hand in between so that easily you get a plane and you deliver the baby. So placenta will come around say later on, no problem. Okay, so it is not an adherent placenta because all of us are sure about that. So this is what I have already said, that the preferably cesarean section should be performed by a senior obstetrician. If not, at least maybe the senior obstetrician should be around, and the senior anesthetist also. Blood should be kept available in ample quantity. Regional anesthesia should be preferred. Facilities for fluid warming, if at all you need fluid aggressive resuscitation, you have to give large quantity of fluid. So fluid warming and rapid infusion facilities should be available. And of course, in transverse lie, the vertical incision should be taken because many a times when you have placenta previa, usually it is transverse lie or oblique lie, maybe, that can make the delivery of the baby difficult. Already you are close to the placenta that is bleeding. So give a vertical incision on the abdomen. That is what we are saying. Okay. So because you need manipulation and effective measures for the PPH, as we have already said, pharmacologic, that means you give carbetocin and methergine. You can do tamponade. What I have suggested, you just compress you pressure or balloon tamponade, hemostatic sutures, and then of course the uterine artery ligation, internal iliac ligation, everything. If facilities are available, the interventional radiologist can go for even bilateral uterine embolization. Okay. So the case was very well discussed, Dr. Anita.
Thank you, madam. Thank you.
And now we go to Dr. Pragati. Pragati, we have this patient, second gravida, para 1, 9 months of she comes to you with strong labor pains. And Somebody's, there is some noise. I think I request that person to mute yourself. I don't know from where the noise is. Can anybody mute? Piyush?
Piyush, can you please check? Can you see?
Wait. Can somebody mute this? This noise is coming from where? Can you please mute that particular account? So I would go ahead with this discussion now. So we have this patient with labor pains, pulse rate is 100, BP is also good, vitals are stable, uterus is full term contractions very good, 40 seconds every 3 minutes. The contour is well maintained, head is fixed, the fetal heart is also good. The patient starts bearing down and suddenly there is rupture of membrane and a fresh gush of bleeding. Okay. So there is a drop in fetal heart rate. What is your diagnosis, Dr. Pragati, and how will you manage?
Yes, from this history, as patient was going on well, and suddenly she started bleeding. It seems to be a case of abruptio placentae. That means the placenta has been separated before. And I will first I will.
Pragati, I would interrupt you here. See, you can see uterus. The uterus is full term. Contractions are just adequate. Contour is well maintained. Okay. Contour is well maintained. And now you have a fresh gush of bleeding. Because if the contour is not, contour is well maintained, how do you differentiate the placenta? I mean, abruptio placentae. How do you diagnose abruptio placentae? What signs we should have?
Ma'am, in abruptio placentae, there may be tenderness in abdomen.
Yes.
But as this is a registered case, already registered. Therefore, we can say that it must not be a case of placenta previa. Otherwise,
that is sure because the head is also well fixed. Okay.
Yes.
And I will already. Yes.
And I will also ask about the history of first delivery, whether it was normal delivery or it was
it is normal vaginal delivery. That is why there not no specific mention about that.
Yes, I can understand that it is a normal delivery.
Yes.
If it is already registered, that it should not be a case of placenta previa.
Agreed. She is not a case of placenta previa. She is normotensive, non-anemic. Everything is well maintained. Only with the rupture of membrane. I give you a clue. Only because of rupture. We have discussed that case.
Either there may be filamentous insertion of cord. That may be a cause.
That is vasa previa. Okay.
Vasa previa.
Okay.
But
so
that should also be
mentioned. Yes, you are very right because you do have the differential. From that, you cannot get a final diagnosis. Abruptio placentae can be one. Rupture of uterus can be one because forceful bearing down, she gets bleeding and distress. And of course, ruptured vasa previa. Now, how do you manage this case?
Then if she is bleeding so much, then yes, emergency LSCA should be done. And side by side, we will maintain the fetal and as well as maternal resuscitation will be done.
Mother is absolutely fine, my dear. Because of vasa previa rupture, you get only fetal distress. Okay.
Yes. Yeah. Therefore, immediately oxygen should be given to the patient, and we should rush for the cesarean section.
So, in fact, anybody else? Can we have some difference of opinion here?
Ma'am, if we see the blood, if we do the, we see the nucleated RBCs, then it is vasa previa. So
we don't have so much time. See what the discussion, what the evidence says that vasa previa. I can say Shaili, to make some comments here, Dr. Shaili.
Ma'am, definitely immediate cesarean section is has to be done in this case, and simultaneously counseling of patients and availability of blood should be made.
Yeah. So
because that is the only method to save fetus, because there are chances of high fetal mortality in such cases.
Okay. So I will, So I will tell you that this it is not a problem for the mother. It is not a problem. The problem is with the baby. So the answer should be you have to deliver the baby as early as possible by whatever modality. Okay, she is bearing down. All of you got it? She's bearing down. And if at all she's fully dilated, and she's bearing down, you may just supply a forceps and ventouse and deliver. Okay.
Right.
Because by the time you arrange for your OT and come, the anesthetic is coming from maybe 10-15 kilometers, you may lose the baby. So the answer should be our idea of managing this patient should be the mother has no problem. Mother is very stable. It's a problem with the fetus, fetal distress, and that is because there is a fetal bleeding. This you will not know beforehand unless you suspect it. Okay, and that is why you keep a high index of suspicion that this can be the cause. And of course, you manage deliver the baby as early as possible by whatever modality. You can't deliver. If you arrange for the operative procedure at the earliest, you can go for cesarean section at the earliest. But what the evidence says that almost 60% neonatal mortality, even if you do the rush cesarean section. That is so bad about it. And that is why you should keep a high index of suspicion. And that is why we come back to the discussion. Somebody has talked about, the vasa previa, but not at 5 months. When you have near-term pregnancy, you ask or what is called as admission, how you do NST or admission, that is admission test. You do ultrasonography at labor room admission. Okay.
Yes.
Either in the third trimester near term or labor room admission, you do the ultrasound, rule out the presence of the vasa previa and of course the low-lying placenta also. Okay. So if you have a velamentous insertion of the cord or a battledore insertion of the cord, initially sometimes you have a low-lying placenta that has now migrated little higher up, but the the vessels keep going across the membranes. Okay. And that is why you should have a very high index of suspicion and you should deliver this baby at the earliest. See, you can see this here. This is the cord, this is dividing into these two, and it's going across the membranes. Here you can see the ruptured vessels of the. So this bleeding is not significant. If you see at the naked eye, you'll say, yeah, it is only little bleeding. But this is fetal blood. And because of this, there is a fetal distress. Okay. So now we come to the third case now, Dr. Shelly. This is a case for you. We have this 32-year-old previous cesarean section patient. She has had one male child, 1 year old. And now during second pregnancy, she comes to you only during 6 months because her husband got transferred to your place, suppose. And she comes to you with bleeding fever. Now, when you inquire further, she gives you history of spotting during early pregnancy, and that ultrasound report is suggestive of low-lying placenta. Okay. At 26, when you do the sonography, you find the placenta previa with absent RP leg, and the anomaly scan is normal. At 30 weeks, again after 1 month, she starts bleeding at home. By the time she reaches hospital, she stops bleeding. So you send her for investigations, ultrasonography, and the patient starts bleeding profusely and she collapses there. What is your diagnosis and how would you go ahead with the management of this patient?
Ma'am, this patient with previous cesarean section and placenta previa with absent retroplacental space is highly suggestive of morbidly adherent placenta.
Perfect.
And at 30 weeks, and she has been repeatedly bleeding, and at 30 weeks, she has bled a lot. So
here in emergency, how will you manage?
See, ma'am, when she has come to me, she has stopped bleeding. But still, she needs hospitalized.
We will discuss first when she has collapsed now. How will you manage from this point? Emergency management.
Emergency management, she has collapsed, so she needs resuscitation in the form of fast IV fluids.
Okay.
To maintain the blood loss and simultaneously blood should be. Pardon, ma'am?
Yes. Fast, you have to resuscitate the patient.
Resuscitation is required, and simultaneously blood should be sent for cross matching, and immediately blood should be arranged and transfused. And although she has stopped bleeding, but we may still.
She has not stopped bleeding. Now she has collapsed. That is why we have to manage it. Okay.
So I'll resuscitate her and admit her and transfuse her blood. Tranixa also, tranexamic acid should also be given. IV fluid should be given.
Yes.
And
that is okay. Now support management. Yes, but then what will you do with this patient now?
Ma'am, after resuscitation, I'll see if she has stopped bleeding. Then
no. We are saying that she had stopped, but now she is bleeding so profusely that she has collapsed in front of you.
So, ma'am, she need immediate surgery
Yes.
to deliver the baby, but she should be managed at some tertiary center.
But then such patient who is collapsed, you are not allowed to refer to the other center. If the patient dies on the way, then you are be liable for criminal.
I will resuscitate, and if possible, I'll refer. But if not possible to refer, then I'll do a cesarean section for her. But with blood and proper counseling, because she is a case of morbidly adherent placenta. She is a low patient in shock. There are high chances that she will bleed intraoperative also. She may require hysterectomy.
Yes.
So
So
all
this
these
is what
things
you are
should
supposed
be.
to counsel the patient and relatives. So what I'm trying to tell you is, when the patient is collapsed, you are supposed to shout for help, not only call for help, right? So shout for all your, not only your staff. So can I have some few comments from the expert? Yes, Shajia?
Yes, ma'am. Senior anesthetists and urosurgeons, we must take the help of some pelvic oncosurgeon. Those who are expert in pelvic surgery, we must call them and then plan this. We have to be very quick in our decisions and very fast in whatever we do, urgent blood and everything. We have to take care of the whole team.
This is going to happen only if we are in a very tertiary center. What Dr. Shelley is trying to point out again and again is that if we are not in a center like that, where we have a urosurgeon and we have a very experienced anesthetist and a very senior gynecologist, then we don't need to refer anywhere. So we need a very highly expert kind of team for this.
Yes. So first and foremost, there are two different things to be said. If you are well equipped with a multidisciplinary team, you will manage then and there only. But even if you don't have a team, at least you will resuscitate the patient and make sure that under your observation, with stringent monitoring, you accompany the patient and reach the patient to the tertiary center.
Absolutely.
That is what the message here. If you don't have the facilities to operate or give blood and blood products, or maybe even the obstetric hysterectomy, do not open that patient there. Okay? Do not open the patient. You will do more harm to the patient. But yes, you have to make sure that he doesn't bleed on the way, and you may lose the patient. So before your patient reaches to the tertiary care center, you make sure that things are ready in such a way that you just rush the patient to operation theater and get her operated. Okay, so team, already we have said that we want this specialized team. Incision for placenta previa, we have discussed the same type of incision, liberal incision. Here only you have to map the placenta. Already it's a load, but because it is adherent placenta, your incision has to be vertical upper segment incision. It has to be, because here it is an adherent placenta, right? And
here
then
is the need of a upper segment vertical incision.
Yes.
And we should not handle the placenta.
Yes.
If it is adherent and we will try to remove it, then she will bleed more.
So once you are sure of the diagnosis, you will not try to separate the placenta at any point of time. See whether it is, just getting separated on its own. But if she starts bleeding, then of course you have to make sure that you go ahead with the hysterectomy. So your informed written consent has to be for obstetric hysterectomy. Otherwise, what Dr. Mridula also said, that if in between the surgery, if you go out and ask them that patient is bleeding a lot, now we have to go for surgery, hysterectomy, then the relatives will feel that you have done something wrong, and that is why you need to go for hysterectomy. Okay, so you have to be very, very sure that this patient might require obstetric hysterectomy. That has to be informed to the relatives, and informed written consent has to be taken before taking the patient into operation theater. Okay, so that is how the message goes.
Here I would just like to add one thing, that sometimes we don't have so many ultrasounds, or if we are in a smaller town, the ultrasounds are not that good where they are able to find out fast so early. Then repeated bleeds, patient coming to us during her pregnancy with repeated bleeds, spotting, and persistently a low-lying placenta should certainly raise a suspicion of an adherent placenta. So we have to keep that in mind. So sometimes we are, absolutely caught unawares. We feel, okay, oh, she's a placenta previa. Let me take her up for a cesarean. So if she gives us a history that she's been having spotting again and again at 3 months, then 5 months, then 7 months again, then that we should keep that diagnosis in our mind.
Yes.
Then we'll certainly be better prepared.
Yes, and that is why the recommendations say that,
Neha, can I say something?
Yes, yes, please.
Especially if the patient is a case of previous cesarean section.
That is
we
what I
should
was
have
going to
this
tell them.
suspicion grade.
That even, yes,
Absolutely,
exactly, madam.
Absolutely.
Exactly, madam. That is what I was trying to say. Okay, even if you have such a case and you don't have, expert sonologists, as Dr. Mridula is saying, previous cesarean section, low-lying placenta, you must have the high index of suspicion. Even without any such symptoms, you get, at the time of anomaly scan. That is what I was trying to say, that the recommendation is at the time of anomaly scan, you make sure that it is not placenta accreta spectrum. Okay, you have to go for ultrasonography. Now it is said that the ultrasonography done by an expert sonologist with a good resolution sonography is equally good as compared to the MRI. So there's no need for MRI confirmation for the diagnosis. It is required for mapping the placenta when you are trying to plan the uterine conservative surgery. Okay, and of course, when you have morbidly obese women or a very, posterior lying placenta where, penetration is difficult. Otherwise, ultrasound is good enough for the diagnosis of placenta accreta spectrum. And that is why the message, as Madam Rina has also said, that you make sure that you rule out placenta accreta. So this is the first sentence I mentioned. Any uterine surgery for that matter, scar predisposes her to placenta accreta spectrum. And so no worries and no hesitation to go for a good resolution sonography and specifically ask your sonologist to rule out the placenta accreta spectrum. Okay, so this rest of the things we have discussed with placenta previa, so we're going to skip this discussion. Okay, so with this, I think we have covered almost all the aspects of the placenta accreta spectrum. So we come to Dr. Neha Chandra now. Dr. Neha?
Yes, ma'am. Good evening, everyone.
Good evening. Good evening. So we have this, 20-year-old primary gravida with 9 months, Aminor, and she's referred at around 1 a.m. From the close by small nursing home with a history of, admission at almost a few hours prior to referral. So she was having labor pains, but she was not progressing well. And so, labeling it as non-progressive labor, they decided to go for cesarean section. The staff nurse tried to catheterize, no urine. So on further inquiry, they found out that, even over the last 8 to 10 hours, she has not passed a drop of urine. So now suddenly they referred to the tertiary care center, where on examination, her pulse rate was 110, BP was 110/70. Uterine contractions were very severe in intensity, no relaxation in between. The fetal heart was 120 and dilatation was only 3 centimeter. Membranes were absent and it was altered colored blood. Station was 0. So what is your diagnosis and how will you manage?
Ma'am, in this case, since the patient is having severe pain and she is having persistent uterine contraction without any relaxation in between, and on PV examination, the blood was altered colored. So this could be a case of abruption.
Yes, go ahead.
Yeah, this could be a case of abruption. And in this case, ma'am, for further diagnosis, if we have the ultrasound facility, we can go for the ultrasound.
Yes. What do you see on ultrasound? What do you ask? Whether you do yourself or you ask your radiologist?
Ma'am, I asked my radiologist, and ma'am, I will ask for any retroplacental clot. First, the position of the placenta, whether to know whether it is placenta previa or it is not placenta previa, then whether there is any retroplacental clot which is seen.
Right. So your radiologist tells you that the placenta is normally situated, but yes, there is a retroplacental clot. And the other
Yes.
investigations are hemoglobin 8 gram%, platelets around 1 lakh. PT and APTT, they are prolonged. Fibrinogen is 150 milligram%, and fibrinogen degradation products are present. Now, what is your diagnosis?
Ma'am, in this case, since one of the most common complication of abruption is disseminated intravascular coagulation. So these are the features of DIC, in which the hemoglobin is less and platelet count is less than 1.2, and the PT and APTT are prolonged, and fibrinogen level is less than 200, and so these are the features of
Whether
DIC.
you want to give arrange for blood and blood product first, or you want to deliver this patient with fetal distress already?
Ma'am, since the patient is in DIC, so I would first, ma'am, I will do both the things. I will arrange the blood products. I will arrange the blood product, and simultaneously I will prepare the patient for cesarean section, and keeping fresh frozen plasma. And if the platelet transfusion is usually necessary, if the platelet count is less than 50,000, and if the patient is usually, so we will try to resuscitate her with crystalloids, and in the meantime we will arrange blood products, PRBC, and fresh frozen plasma. And since in this the fibrinogen level is less, so if the facilities are available, we will try to arrange for cryoprecipitate.
Whether you prefer FFP or cryoprecipitate?
In my center I am giving FFP.
That's what I'm asking. So you are used to using FFP, okay?
Yes, ma'am.
You just now let me. So the message here is very, very clear that don't just bother about a fetal distress or this. You have to work simultaneously and act simultaneously. You have to, resuscitate the woman. You have to arrange for blood and blood components. Simultaneously, you have to arrange for the operative procedure, get your best of the neonatologist with NICU facilities, and you have to take an informed written consent once again, because the same lady who is, landed up into a abruptio, APH, already in DIC, very prone for PPH, right? She's very
Yes, ma'am.
prone.
Yes.
So what
there
are
are chances of PPH.
you have to take all the precautions, including, tranexamic acid, as you said, vitamin K, whatever you want to give, and even the blood and blood products has to be, very handy. They should be available with you. That is what, that is how you have to go ahead. And then, as you said, the patient has, what about the urine output? You have talked about that.
Yes, ma'am. Now, since the patient is having anuria, so this is also one of the complication of massive abruption because of acute tubular necrosis. The patient can have anuria. A patient in abruption can have anuria. So,
So, ma'am, it is because of the
very good counseling and consent will be required. A very good counseling and consent will be required for this.
Yes, ma'am.
Yes. So first and foremost, you have to make sure that you are aggressively resuscitating this woman first and foremost, because the hypovolemia is has taken her into anuria. That is it is acute renal tubular necrosis, which is reversible. But if you correct it within time, that she will go into acute cortical necrosis, which is irreversible. Okay, so that is what you have to. First and foremost, the moment you see such kind of patient, as madam has already said, you have to do counseling. You have to tell them right from the beginning. You see the patient that this is a patient who has come into with us in this condition. She has all these problems: abruptio placentae, fetal distress, problems with labor. She's not progressing also, anuria, coagulation failure. So we have to arrange for everything. And in spite of all this, we are trying to save the baby. The baby may also, get into complications and, hypoxia and all those, even the long-term complications you have to think of, and you get it written from them, right? That we are trying our best, but in this situation, the patient has come to it. So whatever we can do, we will try our best. But because what the baby and the mother has already suffered, maybe these are the problems associated. That is what you have to say. And then, of course, how do you manage these patients? Suppose I have said now what you have already talked about IV fluids and blood component. So is it only the hypovolemia you want to correct or something else? What all things you need to correct for this patient particularly?
Ma'am, the coagulopathy also needs to be corrected in this patient. Initial resuscitation should be with the crystalloid RL, blood PRBC, FFP should be arranged, and simultaneously coagulopathy correction should also be done in such patients.
Yeah, so for that you will use FFP and if available cryoprecipitate. Okay, so
Yes,
it's
yes.
not only the volume, but the hematocrit also, the coagulation factor, and the electrolytes also. Okay, and of course, not to forget the sugar levels also. Okay, so because that's the only
Yes.
source you are giving, that whatever you are giving, all these things should be maintained in proportion. Okay, now this patient you are supplementing with oxygenation, this everything. What precaution? I mean, rather, I would say now, how do you decide the FFP how much or cryoprecipitate how much for this patient particularly? She's having 150 milligram level.
Ma'am, in this case, the ratio for the PRBC and the FFP should be 1:1. And we should give at least 2 PRBC and 2 FFP initially to this patient.
Okay. How do you calculate the FFP? How many packs she will require?
Ma'am, we usually give it in the ratio of 1:1. If we are giving 1 PRBC, then 1 FFP has to be supplemented in patients with acute blood loss.
Yeah, but considering her fibrinogen level, how many packs you will require? Consider how do you calculate it? FFP, you calculate 20 ml per kg for a 60 kg average woman, 1200 ml is required. So what is the one pack comprises of 240 ml? Okay, so almost 5 packs are required for such patients. And then how many cryoprecipitates you usually require for such patients?
We have to bring the level to we have to bring up the level to at least 300 because the normal range is from 200 to 400.
Yes.
So if she's 150, we have to raise it by another 150.
So 10 to 15 packs of
10 to 15 cryoprecipitates are needed. Yeah,
that is what crude method of calculation. Definitely, we have to see to it that we take care of our coagulopathy. So severe bleeding, hypovolemia, this all we have discussed that she lands up into renal ischemia, acute tubular necrosis, and if not treated aggressively, she can go into irreversible. Now here the fetus is alive, that is why you have no choice but to go for cesarean section. Otherwise, if the fetus is dead, you may go ahead with the delivery. And then of course, prophylaxis, prevention of PPH, treatment of PPH, we have already discussed. So we are not going to repeat it once again.
This patient will require ICU management after cesarean. She should be shifted to ICU directly.
Yeah, madam, if I will just tell you that this patient was in individual nursing home and she is now shifted to tertiary hospital. So she's already, your message is very clear and very good, but this patient is shifted from individual nursing home to tertiary care hospital where we are managing this patient. So naturally, such kind of patients have to be managed in tertiary care setups. That is what the message is. So, Dr. Mamta, do we have Dr. Mamta? What is this
Yes,
noise?
ma'am. Good evening, ma'am.
Yes, good evening. So, this patient is a 30-year-old section para 1 and previous cesarean section with 36 weeks. She presented with dyspnea around 8 to 10 hours and she came from neighboring district. This is actually a real case happened in South India. Okay, this case is shared to me by one of my very close friend. So this is a true case. So she has history of gestational hypertension, and echo suggested mild tricuspid rigors. When she came to the hospital, she was semi-conscious, pulse rate around 120, BP was 100. Yes, SaO2 below 90%. Okay. And obstetric examination, uterus was full term, relaxed, and they worried what this noise is. Piyush, is he around? I think this noise is really disturbing me. Okay. So, arterial saturation of the oxygen is 90% and less. Full term uterus is full term, relaxed. Fetal heart is good, 130. Ultrasound is done, absolutely no abnormality. That is what the findings are saying. Routine investigations done, and because now this patient has come into this condition, I think the patient was intubated by intensivist. That is what it is mentioned. Shifted to ICU. Okay. And at 6 a.m., this patient developed epistaxis. So she was shifted at late nights, and at around, after dyspnea of 8 to 10 hours, she was shifted to this ICU after intubating. At 6 a.m., she developed epistaxis, bleeding per vaginal, fetal heart is absent. See, you can make out here when she came to you, she's semi-conscious, not breathing well, pulse rate is 120, and of course, the saturation is very low. But she just pushed, they just intubated her and shifted to ICU. At 6 a.m., she developed epistaxis, bleeding PV, and fetal heart is absent. Investigations now suggestive of coagulation failure. You can see here the routine investigations were done. They are saying, and they are normal. Okay. So besides ultrasound, suggestive of rupture uterus with fetal demise. So on admission, they have mentioned USG done, NAD. Okay. So all the findings are into disparity. How to manage this patient from this point of time now, and then we introspect or retrospect what has gone wrong where.
Ma'am, as USG has confirmed that it is a case of rupture uterus with fetal demise, and coagulation profile is also deranged. So it is a case of rupture uterus with fetal demise with DIC. So, and patient's vitals are also not stable. Patient is already intubated in ICU setup. So we will manage patient, manage DIC and plan for laparotony simultaneously.
Right. The findings, now the case appears very simple. Okay. But if you go into the retrospect, then this is what the DIC care. I will just, skip the theoretical part. Basically, you have to restore the blood volume of this patient and coagulation factor, as you have said. And then, of course, you have to take her for surgery. That is for sure. Now, all this we have discussed for the last case, then I will not talk about it. But then what has gone wrong for this patient? When she came, her vitals were quite good, and even the baby was good. Fetal heart was 130. Okay.
Yes, ma'am.
Initially, she had only dyspnea. So from dyspnea from 8 to 10 hours. So could we have could we have investigated her first, then and there only? And if not, then should we have referred her to the tertiary care center at the earliest? So what has gone wrong for this patient?
Ma'am, patient has been referred to us in an unstable condition only. When she reached to us, her saturation was already below 90%. So we have not delayed in anything. We have intubated her. We have shifted her to ICU setup immediately. But she
no, I don't agree with you. I don't agree with you.
We could have done, ma'am, we could have planned delivery at night itself, because that time baby was fine. And investigations were also fine. Blood investigations were normal. So we could have delivered at that time itself. So in that case, the DIC would not have developed, and baby was also alive. And
even the rupture could have been prevented. Rupture could have been prevented if it was not happened earlier.
That's yes, ma'am. Yes, ma'am.
But ma'am, when patient came at night, there was no indication for delivery. When she came at night, we cannot find any indication to deliver her.
Okay. See, if the patient is full term, okay, uterus
She
full
is
term.
around 36
That is
weeks
good.
and she is 36
Actually,
weeks and
they,
she
Yeah,
ma'am,
36. Still
and
okay,
ma'am,
but then
one
if the patient is unconscious, okay, semi-conscious. If the patient is semi-conscious, okay, and you know
yes.
her saturation is going below 90%, do you think that the baby is safe inside? That is one point.
but ma'am, I think we need
Do
to
you
stabilize the
once
patient and
you
find the cause for her condition. Because
right?
at
So
one
you
side we are saying that she is gestational hypertension.
Mm-hmm. Anybody.
Yes, ma'am. We should have operated this patient at that
At
time
night.
only, because she was already dyspneic for 8 to 10 hours. That means patient was in pulmonary edema. There was already history of mild
She has
tricuspid
some problem.
regurgitation.
She had some problem. And what do you think that
SPOT is
36 weeks,
also.
if you operate, you think of the mother first. Okay, first and foremost. And even, you know, when you deliver the baby, the gravid uterus interferes with your resuscitative measures also. So if
Yes,
once you deliver the baby, say 36 weeks is not mature, I mean, not premature, no. 36 weeks is still acceptable. If the saturation goes down, we will lose the baby, as it has happened here, right?
yes.
That is one. Secondly, she was dyspneic for 8 to 10 hours. Why didn't we make attempts to investigate her then and there only? You just intubated her and put her to sleep, right? When ICU, you are not there. So, monitor the fetal heart. Everything has to be taken care of. One more thing I will tell you for this patient, what has happened. Now if you see the retrospect of this patient, that you can see that our investigations, the coagulopathy should be controlled. The cesarean is only when there is severe fetal distress, management of hypovolema, active bleeding, this associated coagulopathy, and tackling everything together is very crucial. So here, what you have to do is you have to remove the baby, deliver the baby before it dies. That is one. That can help in resuscitating the mother, very effectively. That is why you have to take her up for cesarean section. Did you agree with me? Do you agree with me? Do you agree with me? Because just putting the patient into ICU is not going to stabilize her. If she has DIC setting, she is going to see if abruptio. All of you remember what is abruptio delivery interval, and why once you start abruption, why the patient goes into DIC, the coagulation cascade starts. Okay, so it is the abruption delivery interval which is very, very important. The more you wait, more of the placenta will separate and you will lose the baby. And the more you wait, the abruption delivery interval, if it is more, there are higher chances for the patient to go into DIC. That is what has happened in this case. Okay.
Yes.
Any expert opinion here?
Yes, ma'am. We should deliver the baby immediately as soon as she came, because now she landed up in consumptive coagulopathy, concealed hemorrhage leading to DIC and all the complications which we are seeing. It
Yes.
should have been delivered there and then only.
Okay. So now see what this case was. The patient was admitted with dyspnea, so possibly ARDS, and possibly DIC was the reason. Placenta was morbidly adherent, that was missed on ultrasonography, and slowly with that rupture, there was abruptio also. Because of the rupture, the placenta was low lying, it also got separated, and that led into DIC, delayed management, and maternal as well as fetal death. Okay. This is actually a real case happened in South India. That is why the findings, whatever they have provided, I have just put in like this. But this was really very pathetic situation, I would say. That previous cesarean section, near-term pregnancy, when you have at least some things, indicative that things are not good. The mother is dyspneic, and the baby is also previous Caesar. Why you want to wait? Make the baby safe. Even 34 weeks, we said salvageability. Why are we worried about 36 weeks? Deliver the baby. if you had opened at night itself, when you are intubating the patient, why not to go for cesarean section, deliver the baby, see what has happened inside, right? Whether she is bleeding inside, that you have to rule out. And then, of course, overnight, he is admitted in ICU. Even the coagulation profile should have been done over few hours repeatedly. At least, if not the other test, the bedside test of BTCT, not that, but clot retraction time, clot lysis time. These are the things which we should have done as bedside investigations, which are very, very important as far as the DIC is concerned. So that is, this is all theoretical, so I'm not going to go into these details. I just included this because I thought, sometimes some cases may be misleading like this, and you just feel that because mother is not good, we will not operate her. But there are situations where you operate, deliver the baby, and make the baby as well as mother safe. Okay, so you have to calculate the risk with all the investigations.
As earlier, Dr. Sneha, you pointed out that
Yeah.
once we deliver such mothers, they are better off in ICU. We can manage them in a better way in the ICU.
Yes, even for CPR with the gravid uterus, you can't give CPR. With the gravid uterus, their diaphragm is elevated and the compliance is poor. So further compromise on the respiratory efforts also. So, Dr. Mridula, thank you so much for all the contribution. Should we go ahead with this last case?
Yes.
Anita? Yes. So we have this 25-year-old second gravida para 1 with 33 weeks of pregnancy, otherwise uneventful pregnancy. Previous abdominal surgery was, there was no history of previous abdominal surgery specifically mentioned, and there is no history of severe pain in abdomen. The delivery was normal. Each point has its own significance. The first delivery was normal. There was no abdominal surgery, but this lady is 33 weeks had severe pain in abdomen and couldn't stand upright. Okay, severe pain in abdomen. So pulse rate was 120, BP was 90/60, uterine height corresponding, everything is good, but the fetal heart is 120, uterus tense state, and the cervix is tightly closed. There is only little bleeding from the pervaginum. How will you manage this case? What is your diagnosis rather? When first we come to the diagnosis.
Since this patient, she had otherwise uneventful pregnancy, and now she has come with so much of abdominal pain that she cannot stand upright. Here is the catch. Now there can be 2-3 possibilities, ma'am. Either it can be any obstetrical cause, that is, it can be a concealed abruptio placentae, which could cause so much of pain, or it could be a torsion of a myoma and torsion of the uterus per se also, madam, or torsion of the any ovarian cyst which might have been there. So we have to exclude all these factors because these are the most important obstetric causes of acute pain and abdomen at this period of gestation.
Right. Okay, so you hospitalize her, take a high risk consent, start resuscitating her, send her investigation. So Dr. Pragati, the ultrasound shows transverse lie, appropriate growth parameters, amniotic fluid is good, placenta is anterior, but there is a huge subchorionic, hypoechoic area. Placental tissue was thicker than normal. Fetal heart is only 90, uterine arteries could not be visualized. Now, what is the significance of this, and does it confirm your diagnosis? What is your final diagnosis for this? You need to unmute, my dear.
Yes.
Yeah.
These findings are for the same patient, no?
Mm-hmm.
That patient who came with acute
Dr.
pain.
Anita said, yes, these are the differential diagnoses. So we did her ultrasound. These are the findings. Okay.
Yes. Ma'am, there is huge subchorionic hypoechoic area. That means it is abruptio placentae, and uterine arteries could not be visualized even with color Doppler at normal site. That means there is uterus is in ischemia, and that may be the torsion of the uterus. So there is absolutely absence of blood flow in uterine arteries.
Yes, yes. To the extent that sometimes the uterus can even become gangrenous. Okay.
Yes.
So it becomes so much of torsion. The uterines, they become twisted like that. So even so much of compression. That is why, because of ischemia, there is separation of the placenta, which otherwise happens after the delivery of the baby. Now, I will just share with you, this is also a true case from Nagpur. One of our friends has shared this. Emergency cesarean section was performed under general anesthesia because it was so difficult for her to lie down and, give anesthesia, spinal anesthesia. It was a hurried cesarean section. 100 ml coagulated blood was there in the peritoneal cavity. Amniotic fluid was otherwise male fetus transversely delivered by podalic extraction. Large quantity of fresh clots came out. So this was a RP clots, and uterus was ischemic, floppy. So exteriorization was done and uterus was rotated to 180-degree almost. Okay, so detorsion was done, and in a matter of few seconds, the uterine tone was regained, even the circulation was regained. There was no myomas and other uterine malformation. Okay, rest of the things, all of you know how to manage the, abruptio placentae very well. So I really appreciate all of you, for contributing so nicely and proactively to this, discussion. I'm so happy to see Madam Reena Srivastav listening to our discussion. Madam, I would have first few comments from you, and then thank everybody.
No, the discussion was very, very nice. From very simple things to be done by the simple practitioners to what to be done, where the patient has to be sent. Everything was covered very nicely. And the panelists, they have already taken very good into the discussion. Really, when you should know which case has to be touched by you at a small center, which case has to be sent, and some cases like which you brought from South India, what must have been there? Basically, she presented as a pulmonary problem, and they had taken her to the ICU. Because she was pregnant, there should have been an eye over that by the obstetricians. There should have been a reference to the obstetrician, if not, and they should have followed the patient at least for some hours, and they would have got the clue that it is because of this. So, the obstetrics is a thing which so many variety of things can happen at a time, like the torsion of the uterus along with that retroplacental clot. So we have to have things in our mind. We have to be very particular, not taking the things easy. And obstetrics can make you stand anywhere. So very nice discussion, Sneha. You have done it very, very well. And brilliant panelist over there. Thank you.
Thank you, madam. Thank you so much. In fact, that is what the message is. See, theoretical knowledge is there everywhere in all the books and on the internet. If you can search, you will get everything. But whatever you discuss with your own experience and expertise, I think that is the need of the hour. There's no point, all of you have already passed your MD and MS, whatever. So there's no need for the theoretical discussion much, unless, I mean, it's only limited up to the guidelines, what your parent organization says. In case you, land up into some controversy or some legal issues, there has to be some evidence which is to be followed up, and that has to be your parent organizational guidelines. That is why you need to know the GCP, good clinical practice recommendation by FOXI ICOG. But as a managing obstetrician, you must remember that, just putting your patient into ICU and relax, that is not a way to manage our patient. I think as long as you don't deliver the mother safely and give her a healthy living child with intact survival, our job is not over. And that is why we are here to discuss all of you. So far, I would say every obstetrician and the complete team has to be trained with the emergency management. Don't relax by saying that it needs a multidisciplinary approach. It needs a multidisciplinary approach. Obstetrics is such that sometimes you feel that, oh, it's so nice, she's delivering normally and will be free now. No matter of time, you find your patient lands up into ICU. Okay, So that is why every obstetrician should be well versed with the emergency management. You are not allowed to refer the patient when she is in a moribund condition. So you must know how to tackle the emergency, at least the basic resuscitation, including the cardiopulmonary resuscitation. And then once you stabilize the patient, communicate with your friend, or communicate with your colleague at the tertiary care center. See to it that the patient reaches safely there. There are guidelines how to refer the patient to the tertiary care centers.
Yes,
There are guidelines,
yes.
yes, how to communicate with the tertiary care centers, and you make sure that your patient is getting managed. But if you have an obstetric aspect to be managed, keep an eye. Either you should have an obstetrician there in the multidisciplinary team, or you must yourself, give time and have a vigilant, monitoring for that particular aspect. So that is all I think from my side. With my 32 years of experience in the field of obstetrics, I have learned a lot, and I just feel that I should share with you all. Thank you so much. With so much of satisfaction, I'm going ahead in the organization for my further stay, and I require all of your help and support. Of course, lots of votings. Only appreciation and support will not help me. So it's number game. I require your support. So my
Yes, yes. We are there to help you and support you, Sneha. You are
Best wishes, Dr. Sneha. Best
brilliant
wishes.
person.
Thank
My
you.
all good wishes.
Thank you so much.
Good wishes are with you, ma'am. We'll definitely will be.
Thank you. Thank you,
Forward to see-
Reena Srivastava, madam, for being here, and your talk was absolutely excellent.
Yes.
And every time when we see it, it was like going back to the class and listening. So absolutely, it's a wonderful thing. And panel discussion conducted, moderated by Dr. Sneha is always a treat to watch. So many relevant points covered, absolutely all the practical aspects covered. And I must thank all the panelists and my co-expert, Dr. Shazia, done an excellent job, and happy to be a part of this family.
Thank you, my experts, Dr. Mridula, Dr. Shachya, and all my panelists, Dr. Pragati, my dear friend, Dr. Anita Chabaria, and of course, we have Dr. Mamata Jindal, Dr. Neha Chandra, and Dr. Shaili. Of course, thank you so much, Dr. Nutan, for all the efforts, all the hard work for coordination. Thanks, dear Dr. Bharti, for the collaboration, and thank you, the entire team UPCOG. Thank you so much.
And we have big representation. We have big representation from Bareilly over here. 4 of us sitting from Bareilly. So we thank the UPCOG and Professor Usha Sharma, madam, and Dr. Bharti for giving us this opportunity over here. Thank you so much.
Thank you so much.
Well done, Nutan.
Thank you.
Well done, Dr. Nutan. Well done, Dr.
Thank you,
Nutan.
ma'am.
You were always talking to us and coordinating. That was
really
excellent.
worked very hard.
Okay,
coordinating
bye
everyone.
everybody.
Thank you, Dr. Mridula. Thank you.
Thank you so much.
Thank
Bye,
you,
ma'am.
Reena
Bye.
ma'am,
Thank
and
you.
Dr. Sneha, and each and every president and secretary. Thank you. Thank you. Thank you so much. Good night. Good night. It
I
was
just
nice
request
connecting
all of
to
you
each
to
of you.
nominate me first, and then, of course, vote for me. Thank you so
Yes,
much.
yes.
Yes,
Yes, ma'am.
yes.
Bilkul.
Yes, Dr. Sneha. Yes.
We all are with you.
Good night. Good night. Bye-bye.
Good night. And we have 2 more webinars in the series.
Yes.
And I'll keep sharing the link with all the people that I have connected. So
Yes.
we'll keep on learning. Thank you, Sneha ma'am. And we are going to further
I
go
will
in this
share
journey
with
of
all of you the yesterday's recording, which was also very good. You will all enjoy it because, post peripartum cardiomyopathy by Dr. Ramani Devi was a very excellent talk yesterday's, because, now that's progressing. So I will share the recording in this group also. I will share. Okay.
Thank you so much, ma'am. Thank you, Dr. Pragati. Thank you, Dr. Mridula. Thank you, Dr. Nutan and Sneha, ma'am. Good night.
Good night.
Good night, each and everyone. Thank you, all of you, for your kind cooperation. Let's keep learning, each and every president and secretary and our panelists. Thank you. Thank you. Thank you so much. See you all soon. Thank you.
Thank you.
And thank you, most importantly, Piyush of Corona Remedies, for your patient coordination of all the information. And thank you. Thank you, Piyush, once again.
Thank you
Good
so
night.
much. You're welcome. Good night.